status in the hemodialysis suite. The patient has ESRD and has missed the last 2 weeks of dialysis due to transportation issues. Within 30 minutes of starting dialysis, the patient developed nausea, vomiting, headache, and then became confused. The nephrology pager broke, and the fellow had to run to the other side of campus to grab another one. In addition to a neurologic exam and possible CT brain, what else might you do? Mannitol, DDAVP, hypertonic saline, A or B, or A or C? Give you 20 seconds. The answer is A or C, mannitol or hypertonic saline. I see Jiwon there, really excited. All right, we're going to talk about dialysis disequilibrium syndrome, which is actually super undiagnosed. So it's actually caused by cerebral edema due to dialysis. So it is a clinical syndrome that has a very wide range of presentations. It could be nausea, vomiting, confusion, seizures, or even coma. Towards the beginning of dialysis typically is when it happens. The three main risk factors are your first dialysis treatment, an extremely high BUN, no one knows what the cutoff is, and long gaps between dialysis treatment sessions. So we're going to talk about how to manage this. So let's think about why this happens first. So there are two possible mechanisms that are discussed, and we'll go over them in detail. Reverse osmotic shift due to urea, or reverse osmotic shift due to other osmoles. So buckle up, we're going in some pathophys. Get ready for some arrows. The urea is dialyzed from blood, so your BUN goes down. So your plasma osmolality goes down. So your osmotic gradient between your plasma and your brain cells changes. And so water goes into your brain cells, cerebral edema. So the drop in BUN can cause this. So if you haven't been dialysis for a long time and your BUN has been creeping up a ton and you drop it too much, you can get this.
Okay. And then
this is, you can look at the urea reduction ratio, which is the BUN pre-dialysis and post. No one has decided on a percentage that puts you at risk for this stuff. The next is the reverse osmotic shift due to other osmoles. So this is the hardest pathophys, really complicated, but we'll go through it. So bicarbonate in dialysate enters the blood. So your blood pH goes up. Your CO2 retention goes up. CO2 then goes into your brain and CSF. The pH of your CSF goes down. And then the extra protons actually displace the sodium and potassium that is bound to albumin. So that increases your intracellular osmolality, and then water goes into the brain cells. So you don't have to memorize this. This slide serves as a reference for the future if you're wondering what the pathophys was. The management, I'm going to break down things that nephrologists can do. They can do something called sodium modeling, where they actually change the sodium concentration during dialysis, so that affects the osmolality. Or you can decrease the bicarbonate in the dialysate. Things that we can do. We can give mannitol or hypertonic saline. The idea here is that you want to rapidly raise the plasma osmolality because this entire syndrome happened because you dropped it too much. So let's go over all this again. So for dialysis disequilibrium syndrome, it can vary from nausea and vomiting all the way to confusion and seizures. It tends to occur at the beginning of dialysis because this is when the BUN drops. Risk factors are extremely high BUN, first-time dialysis, and long gaps between dialysis sessions. So that speaks to the change in osmolality that can occur because of those risk factors. And potential mechanisms are reverse osmotic shift to urea and other osmoles. So here's a quick little flowchart I made. If you have nausea, vomiting, confusion, and seizures, and if there's no clear cause of symptoms, consider dialysis disequilibrium syndrome. The nephrologist can do sodium modeling and or decrease bicarbonate in the dialysate, and then we can give IV mannitol or IV hypertonic saline. That's all I got. What questions do you all have?
Dr. Patel, one question I have. So for patients that have these risk factors, when they go to dialysis, are the nephrologists like constituting the dialysis to take this into account, or it's just something we should watch out for?
That's a good question. So usually they sodium model in advance so that it prevents it. This is just sort of if you're showing up at the rapid and something happens, this should be on your radar. Good question.
Got it.
All right. Thanks, everybody. Have a nice weekend.